A patient that I perhaps typifies some of the patients with persistent shoulder problems came through that I remember well. It was a lady in her 50s, and she described a history of persistent shoulder pain with a gradual loss of movement, which resulted in a restriction to her day-to-day function, disturbing her sleep, and basically making her life thoroughly miserable. So she had started the journey, as most people do, seeing her GP. She was offered advice on simple pain relief. Then she was referred through the system for an x-ray. The x-ray was normal, and to the best of her ability, she soldiered on, basically. Then she saw a local physio. The local physio had done a good job in that she obviously had some tendon problems at the start with some, what would be described as rotator cuff related pain. And some of that eased, but nonetheless, some pain persisted, but sadly, her restricted movement continued. So we are many months into the history of her problem now, but the pain itself increased and her function decreased. So by the time she came along, she had very little movement in her shoulder. There's a movement to the side we would describe as abduction. So she'd had about 40 degrees of that movement available. And when I tried to get it further, it wasn't that it is limited by only pain, it is actually physically restricted. And she'd lost all her outward rotation, what we describe as lateral rotation. So that was all that she had, virtually to neutral. So this was something we would classically describe as a frozen shoulder or a capsulitis. And she was in the throngs of both the restriction and the pain, limiting her sleep and causing her all sorts of problems. So what we did is that we pulled together a multidisciplinary team. So I started by upgrading her medication with asking the GP for assistance. The GP very kindly offered more analgesia and an anti-inflammatory medication, which helped a little, but certainly just helped to keep her rolling along. And then she allowed me to refer her to one of our local radiologists. And the radiologist, under ultrasound scan guidance, performed an injection procedure into her shoulder called a hydrodistension. So during that procedure, the radiologist had ruled out any other soft tissue pathologies. She didn't have a big rotator cuff tear or any frank bursitis. It was confirmed to be a capsulitis or a frozen shoulder. So the radiologist first injected anesthetic, and then there was a mix of a little steroid and more saline under pressure, to the point that the amount of fluid inside the shoulder had the capacity to stretch this tight, restricted, painful shoulder capsule that was causing her the problems. So as it happened, she was very fortunate in that she had an excellent response to that hydrodistension procedure. And within hours, she could move her arm a lot further with a lot more comfort. At the time, I was away lecturing, so when she came back to the practice, she was seen by one of my colleagues here, very experienced in shoulder rehab, and my colleague Kath was able to pick up the restoration of her function. So over a number of weeks, she was then given range of movement exercises, which helped to both maintain the progress she'd achieved with the hydrodistension and increase and gain on that progress, then slowly working into rotator cuff strengthening and general strength and conditioning as she continued to improve. On discharge, which was 8 weeks later, she had excellent range of motion, very motivated to continue a small amount of regular exercise by herself, and as you can imagine, delighted with the result.